welcome everybody. Again, I am very happy you come to Grand Rounds every Friday morning. It's great to have you here. I think our Grand Rounds are fantastic, so thank you for taking the time to be here. I have a happy meteorological statement, which is it's less than 2 weeks until spring, which is fantastic. And then just remember Sunday, it's daylight savings time, so you spring forward, so be sure you spring forward your clocks on Sunday. A reminder about our chair search. Our second candidate is here. That's Dr. Monica Kraft. She did her town hall last night, and her academic seminar is today at 5 p.m. So any of you who would like to come, please do. She is a pulmonary critical care doc, and her area of expertise is in the asthma arena, so she has interacted with many of our people in the asthma group here at University of Wisconsin. Our third candidate arrives next week on Thursday and Friday, and then we have a little break. But again, next Thursday at 5 p.m., remember that that is when the town hall is going to be, and you're all really welcome and encouraged to come. With that, I am very honored to have our guest Grand Rounds speaker here, and she is Dr. Renuka Gupta. Dr. Gupta is an assistant professor at Weill Cornell Medical Center, and her talk is Wound of Racism, Physician, Heal Thyself. And many of you might know in this audience that our climate survey of a few years ago did show some areas that we really need to work on, and one was physicians reporting discrimination from their patients if they are non-white physicians, and our learners have reported that as well. And so this talk is going to help us to learn more about that and how we start to deal with some of those things. Dr. Gupta, a little bit about her. She did her internal medicine residency at Columbia University Medical Center, and she followed that with a clinical nutritional fellowship also at Columbia University. She is an assistant professor of medicine at the Department of Medicine at Weill University, a position she began in 2011, and she's also an attending physician at New York Presbyterian Hospital. She's a fellow in the American College of Physicians, as well as a fellow in hospital medicine. She's involved in a lot of very impressive things. I think along with the work she's doing with this area, she's very involved with wellness. She developed and initiated a wellness program in the Division of Hospital Medicine, and much like Dr. Mariah Quinn, who is her sponsor today, has been a member of the Resident Wellness Committee as well. And so we are this is going to be an interactive Grand Rounds, so we're in the back. I'm hoping our audiovisual stuff's going to work okay with this, but Mariah's going to be walking around with a microphone, but we're not, well, I guess we kind of are on TV like Oprah, but we're not really like Oprah. So Dr. Gupta, please come up. Welcome.
Thank you. Thank you. Thank you so much.
You're welcome.
Good morning, everyone. Thank you for such a lovely introduction. I think I'm all set. It's an honor and a very great pleasure to be here. And before I begin, I would definitely like to thank Dr. Mariah Quinn. She's been very helpful and instrumental in putting all this together. So thank you so much. So the topic today, what we're going to talk about, is Wound of Racism, Physician, Heal Thyself. I guess the first slide always has to be. I have no financial disclosures. So what I'm going to begin today is by sharing one of my own personal experience with you that I had encountered in the hospital a few years ago. I took over service from one of my American colleagues and was on my way to see this 70-plus-year-old gentleman located in one of the most luxurious floors of our hospital, facing the Hudson River. For many of you who are not aware, it's a paradise. Anyways, the patient refused to acknowledge me and blatantly asked me, "Which part of India are you from?" I replied, "Northern India." 40 years ago, when I was in Harvard Law School, there were no goddamn Indians. And how could there be? You were all slaves then. I was shocked and numbed. He went on, I do not understand why US government started giving visas for such elite jobs to you Indians. And you dare not touch me again, as I will have your license revoked and sue you. And now, leave, get out of my room, get me a real doctor. A doctor who knows how to take care of their patients. I was shaking, my heart was pounding, and tears were rolling down my cheek. I rushed, locked myself in the bathroom, cried, and ultimately left the unit. For the next few years, I had this bag of emotions. I was depressed. I used to cry. I was very embarrassed. Embarrassed because as a faculty, as an attending, I am supposed to be a role model for my residents, for my PAs, for my nurses, my medical students. And here, I failed. I miserably failed. I let everyone down. I also felt very petty. What am I going to do? Who am I going to go and talk about? And what will others think about me? Am I so stupid that I couldn't handle such a simple situation? So this was a huge bag of emotions that I was carrying around. They never really sat still with me until one day I overheard one of my residents sharing a similar experience. And that's when I decided, not only will I learn to handle and deal with such situations, but also coach and train other healthcare providers in dealing with such situations. With that, I started writing about it. Not that I write too well, and not with the intention that it will ever get published, but it did get published in the Annals of Internal Medicine. Not only that, I get a call from my hospital CEO, and believe me, my first response, what wrong did I do? Did I make the hospital look bad? But no, I was wrong. She apologized and said, I'm so sorry that you had to go through this. We want our community to learn more about it. And that's when I got featured in our internal magazine, Health Matters. Just so to let you know, this topic was so relevant that in the same year, another similar article was published in NEJM dealing with the racist patients. I started Googling it, and I found this video on YouTube, which I found very interesting, and I would really like to share with you.
Please see a white doctor.
It's only available after 4 if you're not...
So you're saying in the whole entire building there isn't one white doctor?
Your kid has to...
Can I see a doctor, please, that's white? That doesn't have brown teeth, speaks English.
Your child clearly has more issues with you being his mother than him needing to see a doctor. You are extremely rude and racist. You want to talk about people being at a hospital?
You're brown, you're all attacking
Well,
me.
I'm sure there are other people who are reasonable.
No, it's because you're racist.
No, it's because I'm white.
No.
You're attacking me.
Slurs.
Hold on,
That's not
General,
okay.
step back. This is my personal
She is perfectly standing right, fine here.
So this is real. It's not scripted. You can go on YouTube, Google it, and this will pop right up. So what are we going to do in the next 40 minutes or so? What we are going to do is, I'm going to walk you through what is discrimination, the different forms of discrimination. We'll share some examples. We'll do an audience poll. What is the response of the medical institutions and what is the legal angle to it? What does A may have to say about this? As I imagine, my situation is not unique. In talking to other healthcare providers, this exists. We simply don't talk about it. Why the need to take action? Application of some different strategies, and what's our ultimate goal? Now, before I move forward, I have a request. In order for this session to be a success, your participation and engagement is the key. So please help me. So, what is discrimination? The unjust or prejudicial treatment of different categories of people, especially based on the grounds of race, age, or sex. What are the different forms of discrimination? Number one, color. Was it my color that when I entered the patient's room, he behaved the way he did? Or was it my natural origin? My accent. The moment I started talking, it triggered him to behave, and he said things I do not know. Third, gender. For many women, or probably all women in this room, can relate. As a women physician, patients consider me from a food service, a nursing staff, pharmacist, phlebotomist, even an aide who is good of taking care of their bedpans and their food trays. But if I have male standing next to me, even if it is a medical student, all questions and eye contact are directed towards that person. Religion. In a study, 20% of over 200 Muslim physicians experienced discrimination. Women with hijab, it's a Muslim head cover, experience this all the time. But Muslim men can pass for a Hispanic. Sexual orientation. In another study out of Stanford, they found that 30% of sexually minority medical students hide or do not reveal their sexual or gender identity, secondary to the fear of discrimination. Some patients do not want to be taken care of by male nurses. Any reason why? Anyone? I'm sorry? Perfect. Bingo. There you go. They think they are gay and they do not want to be touched by them. What we are going to do. Thank you so much. We'll have more time in the end to talk about more about this, but your participation is amazing. Thank you so much. So now, what is the response of the hospitals? So in a study, they found that hospitals are normally responsive to patients' racial preferences. They did a study in the emergency department, and they found that women physicians were most likely to accommodate to patient preferences. What about the legal angle? What are the legal implications? 1964 Civil Rights Act outlaws discrimination against individuals based on race, color, and national origin. I'll give you an example. When you go to a restaurant, you don't say you don't want to be served by a Latino waiter. That is prohibiting Title II of the Civil Rights Act. But this happens all the time in the medical industry. 2010 law case. Nursing homes cannot yield to their residents racially discriminatory requests with respect to certified nursing assistants. What does Code of Medical Ethics has to say about this? When I found this, I was very surprised, and I want to share with all of you. It states, physicians can transfer care of the patient if the patient uses derogatory language or continues to have a prejudicial behavior and refuses to modify their conduct. Let me now walk you through the statistics of discrimination in the United States. In a recent study, 6 in 10 doctor survey had experienced some form of biased remarks based on their gender, ethnicity, race, age, or weight. In the United States, 16% or 160,000 physicians are Asians or black, and yet the study found that majority of them are targets of patient prejudice when compared to other physicians. So then why do we need to take action? Anyone, why do we need to take action against all this? Well, these are very painful and shattering experiences. We all know there's an increase in diversity amongst healthcare providers, and this impacts the delivery of care we do to our patients, ultimately causing physician burnout. Now, if you do not want to be part of any of this, I'm going to share with you some strategies that will help dealing with such situations. And what are these? Chain of command. We'll walk through a flow chart, case discussions, communication skills, and simulations, and ultimately the release of bottled up emotions. The first one, chain of command. All of us should be well prepared with the escalation procedures and policies in our organization. Institutions should also set up task forces similar to the one we have for medical errors, comprising of multidisciplinary team approach, consisting of physicians, nursing, social workers, risk managers, to spearhead education and policy changes. Also, institutions should be conducting annual confidential mistreatment surveys for longitudinal tracking and intervention. Second, flowchart. Published in NEJM, Paul Emily states that all of us should be well prepared and in the know-how of this flowchart when we deal with such patients and families. Let me walk you through this very quick. We need to assess the medical condition of the patient. If stable, I mention again, if stable, we need to assess the decision-making capacity and the reason for request. If the reason for request is purely based on bigotry, we need to discuss options. And what are those? Negotiate, offer transfer, accommodate, or limit the unacceptable conduct. Not only that, we have to discuss the impact on the physician. Paul Emily further states, in certain situations, it's ethically appropriate to accommodate. And the example she mentions, that patient is a recent war veteran, and the physician reminds them of an enemy combatant. Now, in that situation, it could be PTSD or it could be biased. Third, case discussions. I myself have served in the Army, and I believe for a fact that simulations are very effective, as armed forces are always prepared for an attack through simulations. Similarly, all of us should be well prepared with certain appropriate set of words or sentences when dealing with such situations. In the Department of Hospital Medicine at Weill Cornell, we have developed and modified the MGH policy against discrimination. If anyone is interested, I am more than happy to share it with you. I'm going to walk you through this real quick. First and foremost, as healthcare providers, we have a set agenda when we enter the patient's room. And it's twofold. One, we need to figure out what's wrong with the patient. And second, how can we provide the best possible care? And with that mindset, we enter the patient's room and we are derailed. What I'm trying to get to is, the back of our mind, we should always be prepared that each and every patient encounter is unique and different. Therefore, establishing a therapeutic relationship between the patient and family is a key. And one of my residents went through a similar experience, and I used one of these appropriate sentences to help with that situation. For example, help me understand why you don't want Dr. Jones. Now, if anyone is Dr. Jones in the audience, my apologies, it's nothing personal. Help me understand why you don't want Dr. Jones to care for you. What are the things that you are concerned about? Tell me what you are afraid of. Believe me, many a times, agreeing to patients and family has a huge impact. It could be commitment to care. You are right. You are different than me. I like to get to know you. Tell me what's important to you. Or it could be out of curiosity. You are right. You are different than me. And what's important is that you are seeking care and I am here to help you. Third, redirecting the conversation. I recognize that this team may be different than what you anticipated. I am also very aware and know that you're worried about your problem and Dr. Jones. With your help, I like to think how we can fix it. Or all NYP. Now, NYP is not New York Police. It's New York Presbyterian Hospital, where I am from. All NYP team members are very qualified. Our top priority is that you receive the best care, and I know that our team members can provide that. Another way, I'm worried about you. With your help, I would like to focus on how we can help you. Ensuring a safe environment to all our healthcare providers is the key. It can be done in many different ways: depersonalization, reflection. But here are some of the examples that we can use. New York Presbyterian Hospital is a teaching hospital, and we believe strongly that our team provides outstanding care, and everybody on the team participates in your care. We are here to help you as a team. We do not change doctors, nurses, or other staff members because of their race, ethnicity, religion, etc. We want to provide you with excellent care and believe that Dr. Jones is the right person to do so. And the last and the most important, educate and reinforce behavioral expectations. Some of the ways we can talk about: we do not tolerate you speaking to our staff that way. Being a patient at NYP means treating people respectfully. If you cannot do that, we will have to make other arrangements for your care. Or, NYP hires the best and the brightest people to take care of our patients, regardless of their race, ethnicity, gender, or sexual orientation. Believe me, I use them all the time, and I would highly encourage all of you to practice it with your team members, your colleagues, and use them when appropriate. They are very handy and very useful. Now last, release of bottled up emotions. Now there are many different ways of doing it. It may work for some and not for others. If there are some ways that you have been using and doing and has been working for you, continue doing so. What I'm going to share with you is some of the ways that has worked for me and my colleagues. The first is share and communicate. When such incidents happen in the hospital, we need to discuss it with our team members, colleagues, faculty, mentors, seniors, advisors, that very day in the hospital. As an attending and faculty on the wards and in the clinics, we need to reflect upon them, either by written, verbal, and why do we need to do this? Why do we need to reflect upon these incidents when they happen? Well, we have to figure out personal biases and help train, educate our trainees. Not only that, the key is role model. I'll give you a simple example. As a third-year resident in clinic, I was in a room with a patient. And I asked the patient, why don't you take your shirt off and wear this gown? I'll come back and examine you. And as I'm walking out the door, almost there, he says, I will take off my shirt if you take off yours. Now, I've spoken about this so, but every time I say this, it's just, so third-year resident, immigrant, no, I just didn't know what to do. I fumbled with the door and left the room. But there I am thinking, what am I going to do? How am I going to handle this patient? How am I going to examine him? What am I going to do when I go inside? With all these things, I just spoke up and I asked my attending, I was wondering if you would come and examine this patient with me to my attending. You knew me better, right? And he says, what happened? Nothing. What is the matter, Renuka? And then I narrated the incident that just took place, right? His face changed. He just asked me to wait. Okay. And he walks inside. Now, just imagine my plight. Third-year resident, immigrant, visa is an issue for me. I have to establish myself here. My evaluations are at stake. All these things going on. But it was already done. I should have just kept it shut, dealt with it like I've always been dealing with. Why did I have to open my mouth? But I did it, right? I'm waiting there patiently. I see him walking out of the door. And then I see the patient walking behind him. And I look at him. I'm still nervous. I just had nothing else to do, right? I just looked at him. He says, I told the patient, there are many women physicians in this practice. And if you cannot respect them, go find care somewhere else. So that's what I mean when I say we need to role model. Second, the art of meditation. Believe me, I still practice it till date, and it's very, very effective. It's a 2-minute Om meditation, which is simply a Wi-Fi to the universe. What we're going to do is, I'm going to demonstrate, and then we are all going to do it together. If you are not comfortable doing it, you do not have to do it. Right? I'm going to demonstrate. We're all going to sit. All of you are all ready. I'm going to get my chair. We'll sit with our back straight. No, I'm just demonstrating. Oh, I love the audience. I love this energy. So, we're going to sit with our back straight, hands on our thighs, palms facing up, and we'll take a deep breath in. When we exhale, we say Om. With the first Om, we think and say in the back of our mind, thank you for such a wonderful life. With the second and third Om, we say, give me the strength to forgive the person who hurt and shattered me. You can keep your eyes closed or open, whatever is comfortable for you. And you can all chant with me. Can we start? Great. Back straight, hands on your thighs, palms facing up. We'll take a deep breath in. And exhale with Om. Second breath in. Exhale. Third breath in. Exhale. I want all of you to rub your hands together and put them on your eyes, as you have a lot of positive energy. Unfortunately, you'll have to open your eyes. Thank you. Okay, so try practicing this and you'll see it really helps you. It calms you down a little bit. Third one. Anyone heard of a newspaper exercise? I'm only going to demonstrate. I do not want to be doing this. So, when you have such experiences, right, and you are not comfortable doing any of the first two, so in your own comfort zone, locker room, studios, apartments, house, med lounge, whatever you're comfortable with, take a stack of newspaper, roll it. By the way, we got this last night when I was having dinner with Mariah. Roll it. And think of the person who hurt and shattered you. And bang this newspaper multiple times on the table. And say, why did you do this to me? Why did you do this to me? Why did you do this to me? Multiple times, and just discard it. That's why I do not want you to do it here. Scientifically proven by Dale Carnegie, this helps release emotions, calms you down, and helps focus ahead, which is so much important in our industry. Right? Now, newspapers are very difficult to find these days, especially in New York for sure. We're all busy on our gadgets, and we read them. iPhone, iPads, computers, right? So someone mentioned recently when I was giving a talk in another institution, what about a damn it doll? So, the latest version of newspaper exercise is a damn it doll. This could be your next Christmas gift to your colleagues. Purpose is the same. It's a small doll, and office, wherever, pocket, whatever is comfortable. When you're upset or angry, you bang this doll multiple times. Damn it, damn it, damn it. And it works. So try it. So I'll take any questions. With that, I'll just end with a very famous quote from Hippocrates. Healing is a matter of time, but it is sometimes also a matter of opportunity. Thank you all. Thank you so much.
Take questions, and Dr. Gupta, please repeat the question.
Yes, I'll try my best.
I was just wondering if you had noticed an uptick in this type of behavior from patients since the 2016 election results with the current climate of incivility that we have.
So I think the question is, since the elections, have I experienced this from the patients? And my team members, yes, and my colleagues. The answer is, it has always been there. I don't want to be political in any form but it's definitely taken a toll since the elections, as you just mentioned. And it's been, I think patients take it as their right to just, not only patients, but anyone has a right to just say anything, anywhere, to anyone. So yes, This has been coming up more so, and I'm experiencing much more than what I used to before. Does that answer your question? Thank you. Yes, please.
Gupta, for a lovely talk and for advancing the conversation. I'm just curious about the steps that NYP took to create such a strong, what appears to be a strong policy to sort of deal with this patient accommodation preference issue.
Thank you. Yes, it's not an NYP policy per se. It's only, they are still working on it. But just because my division, hospital medicine, is a huge, very vast and very diverse. We are 70 plus hospitalists from all around the universe probably. So we needed this for us. You know, hospital is still working on it, and they know we are already following this, but for us, we have been sticking to this and are there to support each other.
Are there any circumstances under which you do accommodate patient preference?
Yeah, as I just mentioned, say for example, if the patient is stable, right, we try not to. Obviously, if you are sick, my first goal, I think as you will relate and all of you will, if the patient is sick, your goal is to just take care of your patient. But in other situations, you generally don't. And the best way that I have learned moving forward is I call out the behavior right there and then. I just don't let it sit with me. I'll give you some examples. So a colleague of mine, an African-American colleague, was seeing this patient, mid-60s, and he was ready to discharge, but he had very big toenails, right? So he said, is there a way someone could clip my nails for me? And she said, I'll try, but generally this doesn't happen in the hospital. It's very hard to, but I'll look for it and see if anyone can. She goes around, and there's no clipper, and the nurses say, we do not do this. She comes back and says, I'm so sorry I tried, but there's no clipper in the on the unit, and I unfortunately cannot help you with this. You know, his comment was, why do you need a clipper when you have such beautiful teeth? So I'm just saying there's never an end to anything, but she called it out right there and then. She says, I'm very upset and frustrated by the way you would say that. I went to medical school and I'm here to help you. And I went out of my way looking to see if there was a clipper so someone could help you with this. But this coming from you, who happens to be so educated, is really taken my trust away from how I deal with the patients and should not go take a step further. And he apologized right there. So I think what I'm trying to say is we in medical school don't have any formal training on how to deal with this, right? We are just dealing with this, and if things happen, which I'm sure most of you go through this day in, day out, that's part of my job. Oh, I have to do this. Nothing big about it. It's okay. It's not okay. Got to call out the behavior, and it helps. It really helps. Try doing it. Yes, please. You didn't need your training today, right?
I was interested in an article in the recent New England Journal about from Mayo Clinic in Arizona about patient survey results showing that black physicians were evaluated highly by black patients, but not so highly by Caucasian patients. And I wondered if you thought about this and whether it means we need to do something up front to cause people just coming to the clinic and maybe not expressing opinions outwardly to value the care they receive independent of race.
I fortunately have not read that article that you're mentioning. I'm sorry about that. But to your question that how do we take care of these patients, I think it's very important to say we are here to help you, right? Outpatient, patients pick and choose what they want, and they Most of them, they already Google search and they have their own preferences, which is okay. And when they are coming to you, they know they're going to be dealing with this white guy, white physician, this age. They know everything before they come to the clinics, right? So they have that. If they don't want to be taken care of by you, I feel you have a group practice. You can say, okay, is this me? You choose one, or this is a group practice. This is how we rotate and this is how we work. We cannot really pinpoint one person to be seen by, to see you every time you come in the clinic, because it's on a rotating service, right? I don't know how this happens here, but at Cornell, if you are in a practice, you cannot have one particular physician. However, in the hospital setting, that's not the case. You are sick, you came in to get care, and we are here to help you regardless. That's the big difference between outpatient and inpatient world.
I think we're going to ask everyone else to please come up for questions, just be respectful of people's time. Thank you.
Thank you very much, everyone. Sorry.